Um, Today I'm going to mention about SUDEP, sudden unexpected death in epilepsy. The reason why I want to mention this topic is that most of the doctors didn't even hear about it, or even if they heard, they don't really know the risk factors, mechanisms that cause this, or the preventative components. Considering that epilepsy affects more than 50 million people around the world and is the most common chronic brain disease, SUDEP is a pathology that should be known by doctors, patients, and their families. So I'm going to mention about these topics in this presentation. What is SUDEP? Sudden unexpected death in epilepsy is defined as the sudden, unexpected, witnessed or unwitnessed, non-traumatic and non-drowning death of patients with epilepsy with or without evidence of a seizure, excluding status epilepticus, and in whom postmortem examinations don't reveal a toxicological or anatomic causes for that. Each year, about 1 out of 1,000 adults and 1 out of 4,500 children with epilepsy die from SUDEP. However, it occurs more frequently in people with epilepsy whose seizures are poorly controlled. Also, the risk of sudden unexpected death in epilepsy patients is approximately 24 times higher than in the general population. So here's the SUDEP classification. It's definite, probable, near, not SUDEP, and unclassified. So let's talk about a little bit about risk factors, especially early onset epilepsy, young individual, male gender, drug-resistant seizures, generalized tonic-clonic seizures, frequent seizures, nocturnal seizures, epileptiform changes in EEG, psychotropic drug use, alcohol or substance abuse, inadequate treatment, rapid drug change, low of anti-epileptic drug risk factors, and mental retardation are also really important in SUDEP. The frequency, this is really important. The frequency of generalized tonic-clonic seizures is considered the most important clinical risk factor for SUDEP. The higher the generalized tonic-clonic seizures frequency, the higher the risk of SUDEP. Other possible related risk factors described in the literature are specific anti-epileptic drugs, and I'm going to mention these anti-epileptic drugs later in the presentation, and also polytherapy with several anti-epileptic drugs are also risk factors. So SUDEP can affect individuals of any age, but is most common in younger adults aged 20 to 45 years. You can see it in the chart. The differential diagnosis for SUDEP includes a number of alternative causes of death, like drowning, cardiomyopathy, cardiac arrhythmia, drug overdose, pulmonary disease, trauma, and intracranial hemorrhage. Okay. So the prognosis of patients with epilepsy can range from poor to excellent. The prognosis regarding developing SUDEP in a patient with epilepsy can be assessed by SUDEP 7 inventory, and this SUDEP 7 inventory is actually about risk factors that I mentioned before. So genetic mutations are also linked to SUDEP. Genetic disorders that cause epileptic encephalopathies and other treatment-resistant epilepsies increase SUDEP risk, including CN1A, CN2A genes. These are the most related genes about SUDEP, and also you can see the potential mechanisms of these genes for SUDEP in the chart. Yeah. So what causes SUDEP? What are the mechanisms? No one is actually sure about the cause of that in SUDEP. Some researchers think that a seizure causes an irregular heart rhythm. More recent studies have suggested that the person may suffocate from impaired breathing, fluid in the lungs, and being face down on the bedding. SUDEP is generally considered to result from seizure-related cardiac dysfunction, respiratory depression, autonomic nervous dysfunction, or brain dysfunction as summary, and also being associated with inherited cardiac ion channel disease and severe obstructive sleep apnea. Cardiac-related mechanisms include reduction in heart rate variability and prolongation of QT interval. This is really important, which can lead to arrhythmias. And also, two specific drugs, carbamazepine and lamotrigine, were considered as potentially increasing SUDEP risks. And I'm going to mention about these drugs later. Also, channelopathies are another risk factors and mechanisms for SUDEP. So the generally accepted final common pathway for SUDEP is profound cardiopulmonary depression. Yep. So let's talk a little more about the respiratory mechanisms. Monitoring of seizures has shown that ictal respiratory changes accompany tonic-clonic seizures and even partial seizures. The finding of pulmonary edema in 86% of patients that suffered of SUDEP may support this obstructive theory. Considering these findings, ictal hypoxemia occurs often in patients with localization-related epilepsy. Cerebral suppression has also been suggested as the primary event in SUDEP. Generalized suppression of brain function includes suppression of respiratory centers in the brainstem, resulting in severe acidosis. Alternatively, excessive post-seizure brainstem inhibition might result transient abolition of central hypoxic and hypercarbic respiratory drive with consequent post-ictal respiratory arrest, hypoxia exacerbation, and death due to hypoxia and cardiac arrhythmia. The image shows the adenosine hypothesis of SUDEP. In the hippocampus, the ADA surge is important for seizure termination and vasodilation, whereas in the brainstem, the ADA surge can suppress respiration, breathing, in addition to seizure suppression. So, for example, if a seizure occurs, adenosine can cause seizure suppression, or in contrary, respiratory suppression that can cause SUDEP. This picture shows actually a study that could be life-saving in the future. Corroborating this hypoventilation theory, studies of susceptible mice with seizures demonstrated that death was reversible with ventilation. If not reversed, these animals die from respiratory arrest after seizure. So this hypoventilation can be reversible, which is a life-saving fact. Cardiac mechanisms. Cardiac arrhythmogenesis can be due to ion channel dysfunction and leave the patient more susceptible for recurrent arrhythmias. ECG abnormalities is more frequently observed in patients with generalized tonic-clonic seizures. And also, tachycardia is the main cardiac abnormality observed during seizures and fatal tachyarrhythmia. In patients with SUDEP, foci of fibrotic changes that predominated in the deep and subendocardial myocardium of SUDEP cases. So focal myocardial fibrosis is also cardiac mechanism. This is really important. Familial long QT syndrome can lead to syncope, seizures, and in the most severe cases, sudden cardiac death. Some studies, so what are the brain mechanisms? Some studies suggest amygdala central nucleus damage may contribute to SUDEP. Patients with epilepsy frequently have abnormalities of cerebellum, especially diffuse atrophy, and this finding is probably related to chronic use of anti-epileptic drugs, age, and presence of generalized tonic-clonic seizures, duration of epilepsy, or the seizure activity itself. Causes also related of SUDEP occurrence. Cerebellum lesion with consequent functional impairment may be a main risk factor for SUDEP occurrence. Left mesial temporal sclerosis. You can see the left mesial temporal sclerosis in the photo. This is observed in some patients with SUDEP. This is really interesting, the role of anti-epileptic drugs in SUDEP. Case control studies identify anti-epileptic drugs as strong SUDEP risk factors, particularly when given as polytherapy or when more than 2 changes of AED dose occur per year. Regarding specific AEDs, carbamazepine was associated with an increased risk for SUDEP in case control studies. And also in a recent study, lamotrigine was associated with an 8.6-fold increased risk for SUDEP overall and 16.5-fold increased risk among women. Lamotrigine has a potential to inhibit the delayed rectifier potassium ion current, and it causes increased risk of QT prolongation, which I mentioned before, cardiac arrhythmia, and sudden death. Sodium channel blockers such as phenytoin and carbamazepine can have effects on the cardiac conduction system too. So what are the interventions for prevention? Mounting evidence affirms that preventing seizures prevents SUDEP. This is the most important thing. Educating patients and families about the importance of seizure freedom, seizure alert alarms, and anti-suffocation pillows might be beneficial, although these interventions are not yet evidence-based. Absence of monitoring during SUDEP is associated with an increased risk of SUDEP, and post-ictal stimulation or oxygen administration is associated with prevention. Basic anti-SUDEP measures that remain unproven include rapid seizure identification, patient repositioning from prone to lateral, ensuring that the mouth, nose, and airways are unobstructed, simple resuscitation, stimulation, it could be tactile or auditory, suctioning, and oxygen administration. Also, there is a rapidly expanding market for seizures alerts and detection devices, including under mattress seizure motion sensors and apps devised for commercial smartwatches. Unfortunately, the efficacy of devices and of anti-suffocation pillows and SUDEP prevention remains unproven. Furthermore, rapid detection of seizures and resuscitation does not guarantee a successful outcome. Preventative strategies for SUDEP include advice on lifestyle measures, preventing airway obstruction through nocturnal supervision and safety pillows, reducing central hypoventilation through physical stimulation, and enhancing serotonergic mechanisms of respiratory regulation using selective serotonin reuptake inhibitors and reducing adenosine. Here is the anti-suffocation pillow. There are a lot of companies that produces them. These pillows let patients to breathe regardless of the patient's sleeping style. Here is the seizure alert alarms. These kind of devices gives real-time seizure alarms to patients. And also, there are some apps that send information about the seizure to the doctor's phone of the patient. Yeah. Okay. SUDEP is still a situation that causes ethical and legal questions and problems, since there is no definite conclusion on its treatment, on its risk factors, and on its mechanisms. Medical malpractice suits have been brought against physicians before who have not informed patients about SUDEP. In Scotland, a judicial fatal accident inquiry into 2 SUDEPs recommended that the vast majority of patients with epilepsy should be advised of the risk of SUDEP. And coroner's lack of knowledge of SUDEP may also hamper good investigation into such deaths. There may be a failure to document circumstances of that. So it is really important to know about SUDEP in every branch of medicine, especially for neurologists and also coroners. You can see the SUDEP checklist for coroners in here. So the dissociation between patients and parents' desires and neurologists' actions partly results from neurologists' fear that discussing SUDEP will cause anxiety but not improve outcomes. Professional societies such as the United Kingdom National Institute for Clinical Excellence and the Scottish Intercollegiate Guideline Network recommend discussing SUDEP with patients after initial diagnosis. So, what can we suggest to epilepsy patients as doctors, especially as neurologists? Take medication as prescribed, avoid known seizure triggers, get enough sleep, avoid drinking alcohol, train family in seizure first aid, and consider nighttime monitoring. So there is a really interesting medical legal issue of SUDEP. So if you're interested, you can read after I finish my presentation. Yeah, so thank you so much for listening to me.
Okay. I'd like to stop this.